The next topic of today's session is about steroid replacement. Are we doing it right? The speaker of this topic is Professor Dr. Tasnim Ahsan. She is a professor of endocrinology in Jinnah Postgraduate Medical Center, Karachi. He is the laureate award winner, and she is the author of multiple national and international publications. I request Dr. Tasnim Ahsan to kindly come to the stage. Thank you, madam.
So, Assalamu alaikum, ladies and gentlemen, and good afternoon. And with the permission of the chair, I'll just start straight away. So that's the scheme of my presentation: consequences of adrenal insufficiency and that of replacement therapy as well, challenges in replacement therapy for AI, and AI cases and an alternative treatment strategy for them. So this is adrenal insufficiency was discovered in the 1940s, the treatment of synthetic steroid for treatment. Addison's were described 100 years before that, and this changed a universally fatal disease into a chronic disease. And after that, after saving these patients, we kind of forgot about, the replacement therapy. Are we doing it right? And only in the last 10 years or so, this question is being asked about what is the effect of this replacement therapy on mortality, morbidity, and quality of life of these patients. And we know that there are problems there. So there is the Addisonian crisis, which we worry about all the time. And then patients have fatigue, lethargy, postural dizziness. And when you replace them, they're constantly worried about weight gain and osteoporosis and diabetes and so on. And whatever you do, their quality of life is seriously impaired in all aspects of a person's life. So the aims of adrenal replacement therapy is to optimize the dose for symptom control. And one symptom that we kind of universally ignore is pigmentation. And that you see only with primary adrenal insufficiency. And that is a problem particularly with us. Most of the data on adrenal insufficiency is from the Caucasian population. So if they get pigmented, they actually feel very good that they have a tan. But, it's not the same for us. So you want to normalize the blood pressure, you want to normalize electrolytes, avoid Addisonian crisis, and at the same time, minimize overexposure to glucocorticoids. You want to standardize the dose, and this standardization has been static for a very long time. We're beginning to question it. And unlike all other hormone replacement therapies, we are told not to monitor ACTH, cortisol levels, or do cortisol day curves. Indeed, there are very few centers in the world who do cortisol day curves. This is the most worrying data that emerged in 2023, and this emerged in the context of mild adrenocortical autonomous cortisol secretion in the setting of an adrenal incidentalloma. And what this shows us that even with very mild elevations of glucocorticoids, as you see in this condition, there is a 15 to 40% increase in the cardiovascular risk factors, and the relative risk of mortality is also increased. And the quality of life is not significantly different. So these patients do not complain of symptoms of Cushing's or diabetes or any of those things. So they're going about with the slightly high glucocorticoid, and this has worried everybody and woken us up for what to do. So we now know that patients with all three types of adrenal insufficiency have premature morbidity and increased mortality. And this high mortality without glucocorticoid replacement is obviously due to Addison's crisis, accounting for about 15% of the deaths. But even when you replace them, their life expectancy is shortened by about 12 years. This mortality gap with the background population can partly be explained by being unrecognized as an adrenal insufficient patient or by inappropriate replacement therapy. And when you give inappropriate or slightly raised glucocorticoid replacement, you have increased risk of osteoporosis and cardiovascular risk factors, infections and cancer and so on. And in this replacement therapy, the circadian mimicry is suboptimal, and I'll show you why. current therapy does not mimic the nocturnal surge in cortisol and the 8 a.m. peak, the highest level. Adrenal androgen is almost never replaced. And there has been this very long-standing, ever since 1940s, a long-standing 50, 60 years of inertia about reviewing or revisiting this topic. And normal principles of hormone replacement therapy, for instance, when we give thyroxine, we monitor with the trophic hormone TSH. Here we've been told traditionally not to forget about the ACTH. So what are the challenges? Why is it so difficult to replace adrenal glucocorticoids? That's because, there is the normal cortisol production is pulsatile with a circadian as well as an ultradian rhythm. So there's a surge at night and then multiple pulsatile releases during the day related to different activities like exercise, like sleeping, eating, and stress, and so on. So that cannot be mimicked. Current treatment causes both over-replacement as well as under-replacement at certain times of the day. And under-replacement, of course, puts you at a risk of Addisonian crisis. Over-replacement, I've already told you what it's going to do. As if this wasn't bad enough, there is also the problem of inter-individual variability in physiological response and metabolic clearance of the exogenous glucocorticoids. So you cannot have a dose for everybody. Every patient has to be looked at differently. Current dosing strategies are suboptimal. So you asked to give hydrocortisone 2 or 3 times a day and prednisolone once a day. And I'll show you why. This slide was already shown in the hall next door. This is just a reminder of how cortisol and ACTH are secreted. And if you see the gray zone, which is night, you have a peak starting at about 2 o'clock, and you have peak ACTH levels very closely followed by peak cortisol levels, so that at about 7:30, 8-ish in the morning is the highest cortisol level normally. And then there are very low levels from 7 p.m. to about 2 a.m., very low levels of cortisol during that period. So this is a publication from 1978. I mean, we had this kind of information, but we have not done anything with it. In the gray zone is 5 patients whose normal patients, controls, their continuous monitoring of cortisol and ACTH levels. And the other dotted and straight lines are the 5 patients who were replaced on hydrocortisone. And the dose was between 20 to 30 milligrams. And you can clearly see the mismatch. And the mismatch is the greatest at night, where there's hardly any cortisol happening to the people who are being replaced, and there is a surge over there. And you can see the over replacement after each dose of hydrocortisone. So there are 2 doses here. Patient spends a long time at supraphysiological levels. So this is, really not desirable. This is elegant work reported in 2021 where 3 cortisol glucocorticoid doses were compared to endogenous cortisol secretion. And here in the green dotted line is the normal endogenous secretion. The curve looks like what I've already showed you. In the gray hashed line is hydrocortisone. You see the overshoots after all the 3 doses. There are 3 doses on board. So there are overshoots and there are undershoots. So even when we are giving it during the day with hydrocortisone, we are not reproducing the physiological pattern. But with prednisolone in green, in red, and with the modified release hydrocortisone, you've got the closest mimicry of the endogenous cortisol. Except that if you look at the early part of the curve, you see that there is, okay, this is not working, the pointer. You see that at 9 a.m. there is very little glucocorticoid on board. And that is a problem because patients wake up, and we haven't been hearing our patients. Patients wake up feeling nauseous, feeling fatigued, not feeling well at all. We haven't been listening to our patients. With whatever drug you use, early morning deficiency is not corrected. So this is something about the pharmacokinetics of hydrocortisone. Daily cortisol production rate, this has also been done, is between 9.9, it's 9.9 milligram plus minus 2.7. You need to replace more because of the first pass metabolism, and it has a half-life of 1.8 hours. That means that you have to give more than 1 doses, 2 or 3 doses to keep the patient at a certain level. And this pitting of dose causes the overshoots as well as the undershoots. So it has a non-physiological profile, and the day curves of cortisol may partly help to resolve this situation. What about prednisolone? So I've all my life worked in a poor man's hospital, and we have always used prednisolone, and that makes us very happy because that's the way that is being described now. We could not use hydrocortisone. And we've been following Karim Miran and his group from Imperial College, and they have described very low doses as far back as 10 years. So we've been using low doses of prednisolone to treat these patients. I can't remember the last time when we gave 5 milligram in the morning and 2.5 in the afternoon. So the other thing about prednisolone is it's less bound to cortisol binding globulin, so more free, more bioactive, more affinity for the receptor, and stays attached for a longer time. So the effect actually continues even after the drug level has gone down. It has a longer half-life of 3.1 hours and therefore can be administered once a day. And assays of prednisolone have now been developed and are being used to titrate the dose. And here's a very, very seminal study that everybody should read about prednisolone, again, work from Imperial College. This is optimizing prednisolone replacement in adrenal insufficiency. Most of the cases here were either secondary or tertiary. Only about 8% or so were primary cases. And they looked at, they defined the upper and the lower bounds, as you can see in the lower panel, and they looked at 4 different doses to see how they operated. So what they were able to show with this study was that a low dose of 2 to 4 milligrams is safe and effective in most patients with AI. Maximum time to peak was 1.7 hours, median half-life 3.1 hours, and you can titrate with the 8-hour dose, which has also been previously 8-hour level, which has also been previously validated. But what they were able to show that you can even check at 4 or 6 hours with equal correlation with the 8-hour level. So this it is cost effective, it's once daily, and this has led to, this was an audit of their routine patients over 10 years or so. Now they're doing a prospective study to look at the same issue, and the previous study that I described you is the biggest prednisolone pharmacokinetic human study described so far. The HyperAid and the PredAid studies have now are all going to be completed next year, but some preliminary results are already through, and they're showing that switching to prednisolone from hydrocortisone, and if you look at the hydrocortisone dose, even that is 17.5 to 25 milligram here, and they switched between 3 to 5 milligrams of prednisolone. The switching to prednisolone appears to be safe. Minor decrease in body mass index and waist circumference has already been reported, and there was no increase in the metabolic risk factors or hematological parameters. And the best thing was all participants decided to stay on prednisolone and not go back to hydrocortisone. And the same thing has been shown about weight. So some patients were shifted from hydrocortisone to prednisolone, others were shifted from prednisolone to hydrocortisone, and you can see that there was weight loss from hydrocortisone to prednisolone as opposed to weight gain with prednisolone to hydrocortisone. So watch out for this HyperAid and PredAid study. PredAid is about osteoporosis. The bone markers are being looked at. Just a little word about dexamethasone equivalence. This has been labeled as a growth toxic hormone due to mistaken assumption that prednisolone is 5 times and dexamethasone is 30 times more potent than hydrocortisone in suppressing adrenal androgen synthesis. And this is actually an anti-inflammatory equivalence. It is not a glucocorticoid metabolic dose equivalence. So when you use that equivalency, you will overtreat patients. So Wilkins and co-workers observed more than 50 years ago that prednisolone is about 15 times more potent and dexamethasone is about 80 times more potent. And when this potency equivalence is used, you will not be over-treating your patients. So something about the pharmacodynamics, so peak levels are achieved within 30 to 120 minutes. This is important because I'll show you why we're doing it. DHEA sulfate is something we never think about, we don't replace, but there is at least one condition where you should be treating with small dose of DHEA sulfate, which is available 25 to 50 milligrams, and that's postmenopausal women who, despite mineral glucocorticoid and fludrocortisone replacement, do not feel well with their symptoms. So with that, I'm going to come to my two cases. These are both cases of primary adrenal insufficiency, and they were being routinely followed up by the pediatric team at a university teaching hospital. And then they switched to adult care and came to us. So this was a 16-year-old girl who had menarche at 15 years. She has regular menses now. She was actually on 15 milligrams prednisolone when she came to us, along with 0.05 fludrocortisone. And initially she had been receiving hydrocortisone and fludrocortisone. So a very high dose of prednisolone. She was still not feeling well, and if you heard her story, you would think that she was cortisol deficient. Progressive darkening of skin, which was very bothersome for her, postural dizziness, and headache and lethargy. And she had lowish blood pressures, normal height, normal BMI. And other than diffuse pigmentation, there was no other abnormality. So straight away, we reduced her prednisolone dose to 7.5, and fludrocortisone was increased. We didn't want to reduce it further straight away because so as to prevent glucocorticoid withdrawal symptoms. And then on a subsequent follow-up 2 months later, she was feeling much better. We reduced her dose to 5 milligram. This is her cortisol trace from her previous pediatric care team that we were able to access. We don't know what the doses of hydrocortisone and fludrocortisone were at each one of these points, but you can see that as she grows older, there are wide fluctuations, and in 2021, she was changed to 15 milligrams of prednisolone. So this is how we got her, and from January 22 to May 2023, we kind of just played along with her and gave her 5 milligram and 0.1 milligram of fludrocortisone. And the red line indicates the ACTH in the morning, 8 a.m. So at baseline around May 23, we checked her afternoon cortisol, ACTH as well, and you can see both the levels are elevated. This was based on a paper we read about checking the 2 p.m. levels to see what the dose effect is. So then around August 23, we took a leap of faith after studying a lot of papers and decided to put her on prednisolone 2.5 milligram and 0.25 milligram of dexamethasone. And this is what happened at the next follow-up visit. So both the 2 p.m. end of dose ACTH effect comes down, as well as the morning court. And she has remained within the normal ACTH levels, both for the afternoon as well as the morning. A very similar story, this time a 19-year-old male, diagnosed at 3 years, darkening of skin, depression, not feeling well, comorbidity of hypog, for which he was receiving testosterone for 4 years, and an examination, pretty much the same thing. Blood pressure slightly lowish, normal height, and normal BMI, and nothing much to report. He had signs of hypogonadism because of his hypog. And this is again his baseline ACTH. So when he was young, his ACTH levels were reasonably well controlled, but as he grows older, it is out of control. And this is where we got him. So you can see that morning ACTH is persistently elevated. We are taught not to measure ACTH. We don't go for it. The reason why we went for it was the lead complaint was hyperpigmentation. That's why we did it. So here, just like the last patient, we decided to switch him to the same. And the first follow-up, a happy camper, both the patients. The pigmentation was down, they were feeling much better at a lower dose, and they were good, they were happy. So this is the equivalence we worked out. Prednisolone 2.5 milligram is equal to 12.5 milligram of hydrocortisone, Dexamethasone 0.25 is another 12.5 milligrams. So the total dose we are giving is 25 milligram of hydrocortisone. This in the blue, the light blue is the old equivalence doses. So we're now thinking of, if you give 5 milligram, the whole prednisolone tablet, and half of this, then you have, then you're going to be giving slightly higher dose of hydrocortisone, hence the half the tablet. We now next plan to do this. Put this patient on a quarter tablet of dexamethasone 0.5 milligram at night, and that will be equivalent to 18.75. So we're going lower and lower with the replacement doses. So this is what we are doing. Our patients are happy, we are happy. We've shifted 3 more patients to this regime, including 1 CAH patient. So this is the current situation with the glucocorticoid replacement therapy, and hydrocortisone 20 milligram through, with the imperial group work is now considered to be equal to 2.5 to 3.3 milligrams of prednisolone, and hence, you know, our courage in going down that low. The pulses trial is another thing that we need to watch out for. It should be reporting soon, and this is pump therapy, pulsatile pump therapy, and I think there we will be able to better mimic how cortisol is secreted, but it's not for us. For us, this is what we have to do. So prednisolone recommended replacement dose, different things being said in different guidelines. 2 to 4 milligrams is what the imperial group is saying. 3 to 5 milligram is what the Endocrine Society guideline of 2016 is saying. And 4 to 6 milligrams, surprisingly, is what the Endocrine Society of US and Endocrine Society of Europe combined guideline published this year is saying. So there is a difference of, you know, ranges there, but the lower the better is the message. And dexamethasone is mostly used for CH, and the dose now recommended is not more than 0.25 to 0.5 milligram. And aldosterone we know about. So in conclusion, ladies and gentlemen, persons with AI have been overdosed and underdosed at some times of the day with conventional hydrocortisone therapy. Anti-inflammatory equivalence doses have been used, as I told you. Mild excess of glucocorticoid has been shown to increase cardiovascular risk factors and mortality. Studies in the last 10 years have established a much higher potency for synthetic analogs of cortisol, which, just like the insulins, are better than the hydrocortisone that we have been using, and I've showed you why. And once daily lower dose prednisolone has a more physiological PK/PD profile than twice or thrice daily hydrocortisone. The nocturnal surge of ACTH remains unaddressed. Hyperpigmentation is therefore unaddressed. Early morning 8 a.m. surge is not there, resulting in fatigue, nausea, and decreased sense of well-being after waking up. And a midnight dose of 0.125 to 0.25 milligram of dexamethasone plus 2.5 in the morning of prednisolone, which is equivalent to what I've told you, 18 to 25 milligram of hydrocortisone, is proposed as a more physiological replacement strategy in primary adrenal insufficiency, at least, but I think it's also for secondary and tertiary, because they will not get the pigmentation, but they will still wake up feeling fatigued and nauseous and not well. With that, I end. Thank you very much for your patient audience.
Thank you, ma'am.